Good afternoon. My name is Susan Lynn Osterly, and I'm the Program Manager for the University of Michigan Center for Value-Based Insurance Design. On behalf of the VBID Center and our webinar co-sponsor, the Smarter Healthcare Coalition, we thank you for joining us today. Our goal is for this to be an interactive webinar, so there will be a question and answer session following each presentation. Please submit your questions via the attendee control panel, as shown in this graphic, and the presenters will address as many as possible within the allotted time frame. Also, a recording of the webinar will be available within 24 hours of the event. It is now my pleasure to introduce the director of the VBID Center, Dr. Mark Fendrick, who will be acting as both moderator and a presenter today. Mark, it's all yours.
Thank you, Susan Lynn. Thank you very much to the VBID staff who helped put this webinar together, and thank very much to our colleagues in this webinar, the Smarter Healthcare Coalition, who've been great voices for value-based insurance design in Washington. I want to thank each of you from across the country, some of you in the afternoon, some of you in the morning, who have taken time out of your busy schedules to phone in today to hear our presentation on the role of VBID and how it interplayed with the coronavirus infection and COVID vaccine pandemic. And want to thank all of the VBID sponsors and collaborators who have helped move the concept of value-based insurance design from an idea that Dr. Chernow and I came up with now well over 20 years ago to somewhat in the mainstream of healthcare policy and transformation in the United States. You all probably know that information on the webinar, as well as any other resources among the topics we will discuss today, you could find on the VBID Center website or vbidcenter.org. There will be a landing page with all the resources that are discussed during today's presentations and more available for you for free access, and we hope you'll visit there. So let's get started. We've crossed well over 125 attendees. It is my great pleasure to talk about how we're going to divvy up the next 90 minutes. The first presentation will be the VBID Center co-founder and my very close colleague, Michael Chernow, talking about the impacts of COVID-19 on healthcare delivery and healthcare system and healthcare financing. I will follow Mike after a question and answer period with him on a discussion of low value care and how that ties into his earlier remarks. And we'll save the best for last as our colleague Katie Spangler, who's been a significant champion and voice for value-based insurance design in Washington, to give us an update on what's happening regarding value-based insurance design in federal and other policy efforts. So if we could go to the next slide, you see a very young and very handsome picture of my colleague, Mike Chernow. I'm extraordinarily pleased to note that not only is Mike a professor of healthcare policy at Harvard Medical School, Mike has recently been named the chairman of the Medicare Payment Advisory Commission, and just wanted to congratulate him for that important step forward. With that, Mike, I'll turn it over to you.
Mark, thank you. Susan, next slide. I do need to get a new picture. I don't have that tie anymore. That should be the rule. When you throw out the tie, you need to change all your pictures. Anyway, everything I say today is really just my opinions, not those of MedPAC. I do have a wide range of thinking about the impact COVID will have on the delivery system, and I'm going to talk about it now. First of all, the credit for the graphic of the piggy bank with the mask goes to Jordan Clark. Most of the clever graphics are really attributable to her, so thank you. But in any case, if you have to step out, the main theme of what I'm going to say is COVID-19 is obviously just an enormous health crisis, and I obviously don't want to imply anything other than that the health effects are really dramatic. But what I'm going to talk about, in part because I'm an economist, is the economic effects. In fact, I think we are going to, at some point, transition from the health concerns related to the epidemic to the economic ones, and those are going to be significant on providers, insurers, employers, beneficiaries, basically on everybody. So next slide. We have been doing some work with an organization called Frisia, led by a colleague of mine, Ateeb Mehrotra, to measure the change in physician visits over the course of the pandemic. This data that I'm about to present in the next several slides is really right off the presses. It was released this morning at 12:01. So we've been tracking the number of physician visits in a large national database, and what you'll see is by, the bottom fell out of the physician visit market mid to late March. By the 29th of March, visits were down almost 60%. There was a pretty rapid bounce back as the nation moved forward and some things began to open up. And you can see that the part that, at least from an economic and possibly a clinical perspective, is concerning is it seems to have plateaued around a 10% drop. If I would have told you in January we would see a 10% drop in physician visits, that would have been a big economic problem for a lot of providers. Now, in some sense, it doesn't look so bad because we were down at 60%, but there is really a continued and sustained reduction in the volume of physician visits. Next slide. The numbers I showed you a second ago are inclusive of telemedicine visits. So some of the reason why the bounce back occurred is because you'll see in the slide, there was a really big increase in telemedicine visits. The units on this slide, 14%, is relative to the number of total visits beforehand. So if you did it relative to telemedicine visits, it went up an order of magnitude. But relative to total visits, the increase in telemedicine visits was still very large, 14%. The interesting thing is there's a lot of discussion about telemedicine being the wave of the future, and I do think much will persist, but there has subsequently actually been a drop-off in the telemedicine visits. So now instead of seeing 14% of baseline visits, we're seeing about 8% of baseline visits. Still an enormously larger amount than at baseline, but not close to where we were, about a little bit more than half of where we were at the peak. And there's going to be a lot of action going forward about telemedicine regulations and attempts to figure out how telemedicine will fit into the healthcare delivery system post-COVID. Next slide. When we started tracking physician visits, the pandemic was much more targeted, but you'll see if you look through the end of March and April, almost all regions had a big drop. We've changed, if you follow, this is our fourth release, the way we've characterized regions, but the main thing to take away from this is that almost all have been affected. One interesting point is if you look at what was going on in Arizona, Florida, and Texas, you'll see that they didn't drop as much and they were rising pretty quickly. And starting in May, you saw this real flattening out. And so now, in fact, the cumulative drop in Arizona, Florida, and Texas, this is as of the week, this is all as of the week that was beginning in July 26th. So that's basically the last week in July and the very beginning of August. You'll see that those states have now less visits, a bigger drop relative to others. Next slide. So it varies a lot by specialty. The samples get small, so there's some noise. So I don't think that the derm increase, which looks like it was a lot from baseline, is really real. I think if you keep going, in time, it will come back closer to 100%. But basically, derm seems to have done better than others. If you look at certain other areas, pediatrics, pulmonology, orthopedics, neurology, some of those specialties, the drop remains really very significant. So there's widespread differences across different types of practice in the visits, and that has important clinical ramifications, but I'm not sure we have yet sorted out what those clinical ramifications are. And I think there's going to be, for people like me that mostly do research, a lot of interest in understanding what we're losing in terms of health when all these visits went down. Next slide. The other issue that matters, of course, is by payer. And interestingly, the visits amongst Medicare patients who were the most vulnerable to COVID was the most dramatic, but they're also the people who may need the most care. And we've seen a much more rapid bounce back in Medicare. And now basically Medicare and commercial are sort of at the same place. The commercial number is a little bit misleading because that's visits by people with commercial insurance, but in fact, the number of people with commercial insurance is dropping a little bit. So it's the lower visits in part because there's fewer people with commercial coverage. And of course, Medicaid, some of the rebound is because more people might have Medicaid coverage. Next slide. It's not all about physicians. In fact, I would argue an enormous amount of the discussion has been around hospitals. Hospitals have lost admissions. There was some discussion that they would get a lot of business because of COVID. So the first point I want to make is the admissions that they lost far outweigh any COVID admissions that they have. The COVID admissions also skew towards Medicare, which has lower payment rates than commercial. Outpatient procedures have dropped significantly. The numbers are very similar in many ways in the data I've seen to the physician visit numbers I just showed you. The payer mix has been deteriorating again because of the Medicare COVID. The COVID admissions are Medicare, and people are losing some commercial coverage. I would be remiss if I didn't talk about the increased cost for hospitals. There's a lot of reconfiguration of floors, a lot of attempts to get PPE. There's a lot of concerns with staffing. There's been a lot of federal support. So the CARES Act gave a ton of money. There's been some advanced payments, some accelerated payments through CMS to get some money. So the economic consequences to hospitals have really, really been significant, but there's been a lot of money pumped back into the delivery system at hospitals in general. And in fact, some numbers that I've seen suggest that the money that's been pumped into the system actually exceeds, at least so far, the added costs and the loss in revenue. So the next slide. So what you've seen somewhat paradoxically is despite this, and again, I can't overemphasize how important the drop in volume in hospitals has been economically, but because of the financial support they've received, you've seen HCA reporting higher earnings, university health systems reporting higher earnings. In general, I've seen broader data that suggests hospital profitability has not suffered broadly. I'm sure there's a ton of heterogeneity, but by broad classes, it seems that the fiscal support that was provided has been enough in many cases to cover the problems. The question becomes how long that will last. And the big challenge we're going to face, and I'll get to this at the end, is if we sort of muddle along with 10% lower volume in a range of ways, the amount of support and the reconfiguration and the economic consequences of providers just gets bigger and bigger and bigger. And as you know, we're in the midst of a standoff between what further support to give. Next slide. There's a bunch of other settings. I don't think you can really talk about COVID without talking about a lot of the post-acute care settings. I don't have great data on it, but the long-term care system is really challenged. An enormous percentage of the deaths, 40–50%, have been in long-term care facilities. The risks to the staff and the patients are huge. Concerns about keeping the staffing up, getting PPE, and those are well known. The point that might not be something you've thought about is, of course, you can't have post-acute unless you have acute care, and the drop-off in acute care means a drop-off in post-acute care, some of which is profitable. So there really are large challenges in many settings besides hospitals and physician offices, and we're going to have to think about how those settings are going to respond in terms of consolidation, going out of business, and the sort of financial viability of different parts of the sector, because we're concerned a lot about consolidation, and we're certainly super concerned about access. The next slide. So I like to say things about pharmaceuticals, although I don't have much to say about them. Not a lot of people are talking about broad pricing issues, at least for now. There will be some discussion, and I'll return to that later. There's a ton of discussion around pricing for vaccines and pricings for treatment, and there may be changes in prescriptions because of the visits. I'm not so sure, but the big challenge is going to be, we have an enormous problem with COVID. How much should we pay for things that might either prevent the disease with a vaccine or treat the disease? And that is a big, very challenging issue that if you ask me about, I will claim technical difficulties and just leave the webinar because I don't have an answer. Next slide. So there's some big questions about how much volume will return. There's going to be fewer accidents as people drive less, although at least here around Boston, the traffic is picking up again. There's going to be some lost management services. So people that were getting a visit to manage their chronic conditions every 3 months, some of those will just be pushed off for 6 months. In some cases, people have symptoms will just diminish and then they just won't get care where otherwise they would have sought care, but they just got better on their own. People do remain scared of health centers. There's going to be some capacity issues. So once we begin to really pick up, there's a question about how long it will take to get through some of the services that were needed but delayed. A few other things that are important. One of them is that the economic consequences for employers may cause them to reduce the generosity of coverage, which will have ramifications for access to care going forward. Higher deductibles, higher cost sharing, things like that. And then we're still not sure how permanent certain practice pattern changes will be, like telemedicine. A lot of that will depend on the changes in the regulations and which ones are permanent. I mentioned already that there was a big increase in telemedicine. There's been a drop off of that increase. And I think we're going to have to see if we go back up or if we sort of plateau. And I think there's a lot to be done there. Next slide. In terms of what comes back, this is from a webinar I published with Mark and Francois Debron from Signify, using data from the BPCI, that's the episode-based payment program in Medicare, to look at what happened. Our data went through June, so it's more out of date than the earlier one. But for certain services, you actually saw a really big bounce back. There was a lot of concern, for example, that there was a reduction in the number of heart attacks being treated, leading to concern that people are at home suffering from heart attacks that are untreated. So you saw a 25% drop. That had almost completely bounced back by June 8th. But if you look down at, for example, spinal fusion surgeries or major joint replacements, there is still a significant drop off. So they're almost 50% below where they were at baseline as of June. So there does seem to be an uneven return of volume, and there's going to be a lot of attention, as I mentioned, with physician services to hospital services about what the clinical consequences of these changes in treatment patterns are. Next slide. So my bottom line from all of this is I think total healthcare spending is going to be 5% below where it otherwise would have been. I would have told you a few weeks ago that it might be a lower number than that because we were having a bounce back, but now that I see we're plateauing at about 10% below or somewhere around there, it might be a little bit above 5%. But I do think that net of everything, total healthcare spending in the United States will be lower, perhaps significantly lower than it otherwise would have been. I think 2021 is going to be flatter down. Some people think it's going to be up because of the sort of catch up for things that were delayed. That might be true, but I think there's going to be less benefit generosity. Some things will just get better. And overall, I don't think 2021 is going to be a particularly up year. Again, I could be wrong. So we will see. And after 2021, I think we're going to still be a little bit lower because I think the generosity and the economic consequences are going to drive spending down, even if we're past, hopefully past, the clinical ramifications of COVID. The big unknowns, and the reason why I will back away from all of my specific numbers, is I have no idea how long this prolonged first wave is going to go. We're still having 50,000-ish cases a day in this country. Pandemic seems to be moving from place to place and coming back in other places. There may be a second wave people are worried about. There's a lot of issues about how we deal with the pandemic, and understand that the clinical trajectory of the pandemic is what's driving everything. And I think there's a lot of uncertainty along those lines. A few other points in the healthcare space. There's a lot of discussion about what this means for insurers. The obvious point is insurers are spending less money. Every time that people don't go get care and the money's not spent, that money is saved to somebody. And to some extent, insurers are therefore spending less money. Now, understand that because of the medical loss ratio rules, it's not really, not all of it is the insurer's money. Some of that money has to be refunded back to the customers. So people have mentioned, for example, that auto companies refunded certain money back to the customers. The point was the money, because of the medical loss ratio rules, belongs in many cases to the customers. And in the case of self-insured administrative services only customers, which are large employers, that money isn't even being stuck with the insurers. The insurers are just getting paid a fee. It's really the employer. So, for example, I have the privilege or maybe misfortune of chairing the Harvard Benefits Committee, and to the extent that Harvard employees and their dependents use less care, that's not our carrier's money. That's money that we, Harvard, will save. We would rather our employees be treated for things they need, but the point is the insurers aren't capturing that money. There's a lot of concern about risk pool deterioration in all of this. We have a real concern that as people lose coverage because of the economic consequences, the risk pool might deteriorate. So you could actually, if healthy people are losing coverage, and I'm not sure they are, we have a project looking at this, but if it turns out the people that lost coverage tended to be younger and healthier, perhaps because they're working for small firms, the risk pool deteriorates, premiums could go up, even if spending on a risk-adjusted basis isn't changing. So insurance always requires some attention to the risk pool. There's also a bunch of new costs that the insurers are incurring. In some cases, they're waiving co-pays. They're paying for COVID testing and a bunch of other things. And the prices, particularly for out-of-network care, I've heard described in some settings, is out-of-network on steroids. I'm sure that varies across a lot across the country, but the insurers do have a legitimate point when they claim that they have rising costs and various other things are going on that they didn't anticipate when they set their premiums. A few other quick things. Grace period. Some insurers are maintaining coverage for folks even though they're not paying premiums. In some cases, the insurers are giving extra support to the delivery system to help the delivery system survive. And I had made parts of these slides earlier, and I had put low investment returns because at parts of the pandemic, the stock market just plummeted. Somehow that seems odd today, so maybe I'll just brush over the last point. The key point is understanding what you think is going to happen to investment returns going forward does matter to insurers. It was really bad, now not so much. Anyway, next slide. And next slide. I'm sorry, I skipped the next slide. If you take all of those bullet points together, what seems to be the case is, at least in the short run, insurers have done well. United reported significant profit. Some other health insurers have reported some significant profits, particularly in cases like Medicare Advantage, where the premiums are kind of set. But in any case, so far the insurers have done well, I think because of the benefit of not spending money. How much of that they get to keep and how much of that they have to spend later as care comes back remains an unknown. The providers have done well because they've gotten a lot of aid. And the question remains how much, when the end comes back, and how much more aid they can get. Next slide. So I want to talk about some bigger things to sort of finish up my portion of this webinar. The first one is we are moving into a world of just an enormous deficit. I think we're going to get maybe 3 trillion this year. National debt's approaching GDP, 100% of GDP. We're in a big recession. I'll give you some slides in a minute, but the economy is doing far from well. And what that means going forward is everybody, private sector and government sector, is going to be looking to save. Next slide. So to give you some idea of the deficit, this is some relatively recent projections from the Bipartisan Policy Center of it. If you can see where the deficit moves over the course of the year, you can see this year we're approaching 3 trillion, and the CBO projected the end of year fiscal year 2020 deficit to be almost $4 trillion. That's just absolutely enormous in the grand scheme of things. Next slide. What that means in terms of debt is we're approaching where we were at the end of World War II in terms of debt levels. It's okay in some sense because interest rates are at rock bottom levels, but we are going to have a big financing problem, and we will have continued debates, as we are now with the current debate about further aid, about how much we can afford to spend as a country. But the debt and deficit picture are really disconcerting to people that are worried about those types of things. Next slide. In the private sector, there's just been this enormous employment drop. Oftentimes people say with hyperbole that we went off a cliff. This is about the best picture of going off a cliff. That even if you look at the Great Recession, we kind of slid down a steep, but slid down a hill. Here, we literally went off a cliff. And while everybody's hoping for a V-shaped recovery, and there has been a bit of a V-shaped recovery, the employment report, I think it was today, maybe yesterday, that we had first-time unemployment claims less than 1 million. That sounds great, but understand that is still roughly 5 times where we were beforehand. We have now made unprecedented recovery and are still in a disastrous economic situation. And if we don't get more aid to keep the economy running, and I think the only thing that has kept the economy running has been a lot of federal fiscal support, we run the risk of dropping down significantly again in terms of employment. And I say that somewhat analytically, but behind each of these numbers are people that can't pay their rent, the food banks have a lot of people going. There's an enormous amount of economic uncertainty and economic suffering that's going on in the country right now, and that's going to have really dramatic ramifications going forward. Some of the dislocations are just unthinkable relative to where we would have been if we were having this discussion in January. Next slide. So bringing all of that back to healthcare, it's important to understand that Medicare trust fund, which was challenged to start with, is even more challenged. It's not due to spending. Medicare is probably saving money due to spending. You saw the slides I put up before. It's because the payroll tax that funds Medicare has brought in a lot less revenue. And so you could debate I haven't seen the latest numbers in terms of Medicare Part A trust fund fiscal stability, but we're talking in the next few years, depending on what happens, and we'll see. I still have, for the life of me, not been able to figure out how this is going to work with the payroll tax holiday that they've been discussing. Some of that's just a delay, so maybe that money will come back. But we have a significant decline in revenue that has significant ramifications for the trust fund, and that's going to be in the next administration, be it a continuation of the current administration or a new administration. There's going to have to be an immense attention to what to do about the Medicare trust fund and how to finance it, and understand that that's coming in an environment where our deficit and debt are really at historic levels. So next slide. I wish I had some solutions, and that's why it's nice to be the dismal economist, and then I can toss it over to Mark, who's much more optimistic by nature. But there's only a few ways to save money. One is to have lower prices in healthcare. One is to have lower prices. The other one is to reduce utilization. Realize that either take revenue away from the healthcare system, and the entire theme of the beginning of my talk was the healthcare system is unbelievably challenged in terms of the revenue they're getting. But the point remains, Medicare prices are already on a very flat trajectory. For physicians, for example, in the MIP system, they're flat in nominal terms between now and like 2090 or some other, I don't know, long run point, essentially. And the Affordable Care Act, there are productivity adjustments that lower the trajectory of fees. So most fees are on a pretty low trajectory. There are some places where there are opportunities to save money. Some of those are reported in MedPAC reports, but I think by and large, the price trajectory in Medicare is low, and there's a lot of attention to commercial prices. So the solution in some ways is to try and build a more efficient healthcare system, and that's going to involve some aspect of reducing utilization. And the key there is to reduce utilization of low value care. The healthcare system is providing a lot of care that we need. We want a well-functioning healthcare system with access to high value care, but the way we're going to have to begin to think about solving some of this is at least in part to focus on low value care. I'm not sure how far we can get in that direction, but luckily I get to turn it over to Mark Fendrick now, who is the guru of all things low value. So if there's any questions for me, I'm happy to try and answer some. Otherwise, I will let Mark begin his portion of the webinar.
Thanks. Not so fast, my friend. Michael, that was amazing. You're going to take a couple questions. I want to thank the folks who've already entered a whole bunch of interesting questions. And Michael, I am the low value side of the dog and pony show. So I'm going to ask you to behave as you like to see in healthcare in a more globally budgeted way when I ask you questions, to try to keep your answers short, because I have a fair number of questions to get through in the 10 minutes we have allotted for you. You good for that?
Yes.
Okay. First question has a lot to do with something you know very much about and studied. What do you think the COVID-19 pandemic will do in terms of encouraging or discouraging the uptake of alternative payment models?
Um, by and large, I think there will be a greater interest in alternative payment models depending on how they are designed. So episode-based payment models, for example, things wouldn't work so well because as the episodes dropped, the revenue dropped in exactly the same way as they would have for fee-for-service. Global payment models could have been a little bit better, like ACOs, except even there, depending on how the benchmark is set, the revenue would go down. And remember, the global payment models have a accountable provider, say the primary care provider or the organization that employs the primary care provider, and so it might not work quite as well for specialists. So I think this gives us an opportunity to design better alternative payment models, but is not the case that if we simply move to existing models, we wouldn't have had this problem.
Great. Okay, as I sit here looking out at the fabulous Ann Arbor VA Medical Center, you know that the VA of all health systems has probably done the best of any large health systems in the U.S. given their financing. But I'll move on to the next question. So you did mention this dramatic near overnight uptake of telemedicine and virtual visits. One of the reasons that drove that, of course, compared to pre-coronavirus pandemic levels, was the legislation and regulations that led to very generous payment of telemedicine. What do you see for specifically around the payment for telemedicine moving forward?
So first, I'll answer that in a second, and I know you want me to be quick. On the VA, of course, they aren't really part of an alternative payment model. They're just budgeted, so it is an alternative, but it's not a model anyone else could use, at least right now. It's an example of a different approach. With regards to telemedicine, it's one of these things where everybody understands that telemedicine is good, and can offer a ton of value and potentially can be less expensive. On the other hand, it offers an enormous challenge to program integrity, and there's a big potential for just wasteful telemedicine use. So all of the discussions I have been a part of involve essentially trying to figure out how to promote access to telemedicine in the places where it's clinically valuable, and how to fence it in or discourage overuse. The biggest problem that people have, at least the folks I've discussed, is the potential for broad abuse, where you could have program rules that allow people to just churn a ton of really quick remote visits, maybe not even video, but just audio or other types of contacts, and abuse the system that's put in place. And so there's going to be a lot of discussion of what those fences are. I think the world will become more permissive of telemedicine, and the debate is going to be how permissive, what the price will be, and what the fences around that will be. I do think there will be more permissive use of telemedicine in different types of alternative payment models. And that, of course, is one reason why alternative payment models work, is that policymakers are much less concerned about abuse of telemedicine when the system is at risk, as opposed to the payer. The delivery system's at risk, as opposed to the payer being at risk.
Really good answer. One of the things that I and another questioner asked about, which most people are not addressing, which goes back to some seminal work by you and that we wrote about, is the potential for the millions of people who need health care who do not get health care, particularly middle-aged men like yourself. Do you foresee a lot of these, what you called previously, newcomers entering the system, and how do you account for that?
I don't see a lot of increased demand from people that otherwise would have stayed away from the system. There may be attempts by the delivery system to further encourage that type of care, but my gut is that most of the changes that those people will face, higher cost sharing, for example, is going to keep those folks away. And I think the issue is going to be how much of the foregone care comes back and how much of that care that comes back is high value. But I don't see increased demand in any of the real populations. And it remains to be seen the extent to which the delivery system can encourage that added utilization, and if that utilization is appropriate. I'm a little skeptical, but we will see.
Well, you should know that not only here in Southeast Michigan, but we've heard from several others that these healthcare systems that are struggling are really aggressively pushing telemedicine and virtual care to expand their footprint and to attract patients who need high value care who haven't been getting them. As you know, all the high value care services we've described for decades are markedly underused, providing an opportunity to actually spend money on good things. So
Yeah,
along those lines, really quickly, do you have any sense on whether you think the early response from COVID that you and Dr. Malhotra are following has led to a reallocation around value, given that there have been comments in the question about concerns regarding rapid returns of profitable services that may not be considered high value from the population health perspective?
In a very, very top line, I think where we are right now is there has been a somewhat of a rotation to value, if for no other reason than the people that are willing to brave the COVID risks of engaging with the delivery system have been the ones most in need of services. So I think you've seen, broadly speaking, a return of episodes that you might think were higher value, crudely measured, and less concerned of things that you might think were lower value, or at least not as pressing. But I don't think we've done a good enough job of being able to assess the nuance as to what's going on. And back to your point about newcomers, the challenge is to understand how much the delivery system can bring people in and how much what they're doing relates to the people that they can more easily access and affect, as opposed to the people who really need the care. So we will see the extent to which this plays out. But my thinking is, at least in the near term, we probably have lost a little bit more of the low value care than the high value care broadly defined, but we're far away from targeting that the way we would like.
Great. So I'm going to finish up with a Cliff Goodman inspired rapid fire 3 questions for you. I'll give them one at a time. So first question, because I know you've thought about all these issues, and I want to thank all the folks for entering the questions, and I apologize that we couldn't get to all. First is you've written a lot about mergers on both payer and the provider side. What are your thoughts on mergers and acquisitions and their impact in the post-COVID era?
A big potential problem that we need to keep our eyes on, and one of the big challenges with the fiscal problems as the delivery system is facing, is the tendency to merge and have consolidation, and that's a big problem for pricing in the commercial sector, and one of my big concerns.
Second question is, obviously we asked you to cover a whole bunch of things in a short period of time. Regarding your projections and statements about financial losses and recovery, do you think that this is very much regionalized by COVID cases, or it could be extrapolated across to geographic areas where the coronavirus infections have not been as prevalent?
I think to a first order approximation, it's been pretty similar across areas, as areas with few cases locked down despite not having a lot of cases. So I think it's been reasonably uniform. You did see, for example, Arizona, Texas, Florida have a much slower rebound as things really picked up there. So I think for the most part, we're settling in to a system where everyone is roughly 10%, maybe 15, maybe 8%, below where they were, but it's not nearly as variable as the variation in COVID is across the country.
Okay, thank you. Last question, and I'll give you more than a minute because you'd like to think I wrote it. Uh, Seems like COVID-19 may be an excellent opportunity for public and private payers to change their benefit designs around the principles of value-based insurance design. Uh, any crystal ball predictions about the uptake of VBID moving forward?
So you would think that that would be true. My general sense is going to be that everybody is so busy scrambling that every innovative thing has been put on hold for at least a little while. I think the VBID opportunity will grow as people begin to face the bigger crises, economic crises and efficiency crises that the healthcare system faces. But that's probably, I was just, for example, communicating with Peter Lee, and who runs Covered California. And the general sense I got, Peter didn't say this, by the way, so I'm not attributing this. So if Peter, if you're on, text me and complain if I misquote you. But my interpretation was that there's a lot of problems that everybody is facing right now. They remain interested in these types of ideas, but they just got to get their head above water before they can be particularly innovative. And I think that's a challenge in a lot of places.
Well, I could always count on you to give the Eeyore response as we tried to put Tigger into the 100-acre wood.
That's why
Mike,
you're next.
Great,
That's why
thank you. Yeah, and I get to talk about low value care, but on behalf of the VBID Center and the Smarter Healthcare Coalition, thank you very much. We hope you'll hang around for the next 45 minutes or so in case there are further questions come in. But much appreciated. Thank you, Mike.
Do I get to introduce you?
Feel free. Go ahead.
So the next speaker and a close friend and longtime colleague of mine has almost single-handedly brought attention to the issue of value in benefit design, value-based insurance design, and is really now, I think, a national leader in everything related to value, with a particular focus now on low-value care. I can't match his optimism or energy, but that's why it's good to stay on and listen to everything he has to say. So I now give you the director of the Center for Value-Based Insurance Design, and really, I'll argue the headliner here, Mark Fendrick.
I wish my mother were on the phone. Thank you, Mike. So appreciate Susan Lynn, Osterly, the team, and Jordan Clark, as you mentioned, for these fabulous slides. And as someone who was seeing patients this morning outside, this is the building where I'm sitting right now. It's really important for all of us, Mike, Katie, and I in the VBID Center, to send our thanks to the selfless people who are doing so many things to defeat this pandemic. So hail to the front line. Next slide, please. So many of you have heard the issue about healthcare costs being top line. I think a lot of it has been subverted by the COVID-19 pandemic. It is my guess, and from what I'm hearing rumblings, that healthcare costs will return as the presidential and other national elections come back to the fore. I think it's particularly important in light of Mike's comments about the fiscal situation at the macro and the micro levels, is that, as always, there's more than enough money in the U.S. healthcare system. We have argued for now over 2 decades that it's spent on the wrong services in the wrong places. People like Mike and others are focusing on alternative payment and pricing models, but we also have to remember that there is a demand side or a patient-facing side to this issue, and the better and quicker that we align incentives for both providers and patients, the better off we will be. It is my concern that listening to stakeholders complain about pleading poverty for my entire career, the evidence from Mike's presentation suggests this is clearly the case on the provider side. I'd like to think that these surpluses that health plans and self-insured employers have on the healthcare spend side, although employers are hurting in other aspects of their business, that they might be willing to think about reallocating their healthcare dollars to things that work and doing their best to prevent the recurrence of those low-value services that are not making Americans any healthier. And it's been really somewhat discouraging to me that for those of you who've been following the VBID movement for quite some time, that we've heard from several payers basically saying that given the financial crisis that XYZ organization is facing, the areas of blunt like deductibles and cost sharing, sadly, are likely to turn to the fore. And it's my hope that some of the points that we will make here in the next half hour or so, maybe a little less, will be of interest to you moving to realize that there are more clinically nuanced ways to come out of the COVID-19 pandemic, increase generosity on the things that we believe make Americans healthier. And the driving force for that, as I'll talk to in some detail, is finally taking on the challenge of identification, measurement, and removal of low-value care. Next slide, please. So COVID-19 was bad enough, whether we call it a first wave or a second wave, but I think what's really interesting, and Mike glossed over this in its more economic perspective, but in that Health Affairs blog post, which is on the webinar webpage, it was really interesting to see that one of the worst parts of the COVID-19 pandemic was the fact of the near complete shutdown of these emergent, urgent, high-value services that we always have to have on a continual level. So whether it be strokes or heart attacks or other of these urgent, emergent things like appendectomies or serious broken bones, we have to figure out a way and learn from the experience to make sure that high-value services remain provisional at a high level, but at the same time, we could allow focus to not allow the resurgence of these wasteful expenditures that can be used as headroom to allow some added money to pay for high-value care. Next slide. So I picked a few of the hundreds of newspaper headlines about what COVID-19 is going to do for providers, for health plans, for consumers, employers, for public plans and private plans. And I like to deter to my favorite health services researcher, Yogi Berra, who said predictions are dangerous, particularly those about the future. Next slide is, we really have to think about what our goals are. And I love this picture that I drew from The Onion. Please note this is not real. That in the earliest concerns when hospitals and health system and practices were going out of business, that basically things were so bad that patients were being rushed into things they didn't need. And for the folks from Virginia and Washington and Maine and other members of the Low Value Care Task Force, I've always viewed this pandemic as a real opportunity, given that we have scarce resources to spend, to shine light on things like unnecessary surgery. But at the same time, as John Rother, Katie, and I wrote in The Hill, that we do our best to make providers whole by paying them generously for the services that we know improve the health and quality of life of individuals and populations. Next slide, please. So this is the model that myself and some colleagues from Tufts University put together. And I'm not sure if our friends from Smarter Care Virginia and elsewhere are on the phone, but my colleagues on the Low Value Care Task Force know that if you look at this slide, the olive lines are low value services. In this case, on the left side, these are real data for high value cancer screenings in blue and low value cancer screenings in green. Better for worse, the COVID-19 drove almost all of these to nothing. And as the Low Value Care Task Force members know, we've been trying to push that olive line to zero. We can't take credit for pushing the olive line to zero, but this is a really exciting opportunity for us that if we were to do a better job to identify and squash those low value services, we actually have enough money in the system to allow not only the blue line to get back to less than 10%, Mike, as you said earlier, but actually go well above 100% to allow those underserved screenings, chronic disease management, things like cardiac rehab and pulmonary rehab hospitalizations to be able to be covered more generously and paid for more generously to ultimately allow this clinically nuanced approach to payment and benefit design. So as Mike knows, this is a dream. I think there are some grumblings around to suggest that there will be a big resurgence of high value care. Whether that line will stay close to zero, academics like Mike and myself and many others on the line will be tracking that very closely. Next slide. So this is what we say, and this is, basically another version of Horton Hears a Who beating the drum. One, as one of the questioners asked Mike, let's no longer pay fee for service. Let's move to some type of alternative clinically driven or quality-based payment model. Two, which is often underestimated in our work that Mike and I do together, is that there's technologies now, unbelievably impressive technologies coming out of the woodwork, not only associated with telemedicine, that hopefully will allow us to leverage these technologies to make it easier to purchase and use high value care, but also discourage the use of low value care. That's through the EMR, that's through scheduling processes, other types of things. And of course, I have to always say that bring the patients involved, align their incentives with the clinicians, that while you pay clinicians more for doing the right thing, you make it easy for those patients to do those things by lowering cost sharing. And conversely, while you shouldn't pay clinicians for doing the things they shouldn't be doing, you should also allow that benefit design to align with that change and deter the use for higher cost sharing. Next slide, please. So while I have been asked to be the low value presenter and talk about low value care, I put this slide in here to remind everyone that I always want to be remembered as the person who fought very, very hard and very long to increase access and affordability to high value care. And from the list of the 200 attendees on the webinar, I know there are several people saying, Mark, there you go again. How the heck are we going to pay for more generous coverage for chronic disease medications, clinically indicated specialty visits, and now how are we going to pay for clinically indicated telemedicine on top of all that? And my answer for the first 10 years of working with Mike is, we'll just figure out a way to get people to draw it out from other aspects of their business, or in the case of the federal government, say, let's cut money on defense and use it on healthcare. So while we were unable in achieving this, the next slide has led us pretty much to take an advantage of a situation which, one, is we have a pandemic and remind people that that olive line is near zero. And while everyone likes to use the term of elective procedures, we have to remember that elective procedures are often high value, things that I beg my patients to do, but they're often low value elective procedures that we shouldn't do at all, leading to this idea of clinical nuance and divvying up the pie in a more quality driven way. So the next slide outlines our approaches to how we could pay for more high value services. First, and what goes back to that insurance class I took over 30 years ago, is what insurance should do is spread the risk across everyone. And to increase coverage for high value care, we should raise premiums. And as all of you know, and certainly in the next 90 days or so to the presidential election, talking about increasing premiums is politically not feasible. Even something as simple as giving Medicare Part D beneficiaries a break on their cost sharing on high value drugs, it has been stalled in DC a great deal, because if you buy more high value drugs, premiums might go up a little bit. While I support that idea, there's a lot of people who don't. So given that we cannot raise premiums on everyone, the alternative for the most part until recently is to raise deductibles and co-payments, these blunt instruments that Mike and I tend to refer as a tax on the sick. So if you're not using healthcare, you don't care what your deductible is. But if you care about the people who are using healthcare, or maybe more importantly, should be using healthcare but aren't, these blunt instruments are particularly problematic. And all of us know what my mother says: you make people pay more for something, they buy less of it. And the impact of deductibles have been far more negatively affect on those with multiple chronic diseases and financially insecure, which is why we at the VBID Center, the Smarter Healthcare Coalition, and my next speaker, Katie Spangler, have been on a quixotic journey to try to make deductibles smarter in this country, limiting the deductibles to care that we shouldn't be buying and making more services pre-deductible, and Katie will speak to that. So how do we pay for this expanded coverage? We can't raise premiums. We can't raise deductibles. So the VBIT Center Advisory Board, after many years, convinced Mike and myself that we had to become low value care people, even though we wanted only to be known as high value care people, but so it is. The next slide. So we went about in an academic and more importantly, an implementation strategy. We created the Low Value Care Task Force. You could Google that and find our work there. We wanted to call it the Waste Task Force, but WTF was taken as an acronym. So we've now assembled about 25 or more public and private payers and key stakeholders. We appreciate the sponsors of the Low Value Care Task Force, and we have been trying our best to educate anyone who will listen about the identification, measurement, reporting, and removal of low value care. We have, as a task force, started with our top 5 list. You see here on the right, there are many other organizations who have their own low value care lists, which are completely fine with us. Many other organizations have taken some of ours and others from Choosing Wisely and the U.S. Preventive Services Task Force. But the key item is, particularly as we come out of COVID, there is an alternative to raising deductibles if you need to keep your actuarial value, your premiums, or your medical loss ratio low. The more you focus on removing low value care, I think the easier it'll be to get to where we want to be. Next slide. So the good news is things are moving very rapidly in terms of uptake of information about low value care. I've said this publicly a number of times. The appetite for savings from reduction of low value care has far superseded the appetite that Mike and I have been trying to cultivate for 20 years to get payers to pay more on high value care services. So the good news is there is a large, growing, and increasingly robust literature now around the concept of low value care. There's even actually a paper showing the number of papers on low value care, how it's has exploded. Not quite the reverse, what's the reverse of a cliff, Mike, but a really big increase of low value care. Lots of superb, young, and more experienced investigators taking this on. I show this slide because one of the areas that Katie will be speaking on is the potential savings of reducing low value care in the Medicare program. And our colleagues out at UCLA Rand published this month in the Journal of General Internal Medicine a study looking at low value services in the Medicare program using the Milliman Health Waste Calculator, showing substantially large hundreds of millions of dollars in easily identified low value care services, and the fact that a substantial amount of the Medicare beneficiaries receive a low value care service in a year, and that it would not take much for Medicare Advantage plans and hopefully fee-for-service Medicare to start examining some of these specific low-value care services you see on the slide, like opioids for low back pain and unnecessary colorectal cancer screening, which is a D-rated service of the U.S. Preventive Services Task Force, to start saving the money to allow more generous coverage on high-value services, which is already starting in the Trump administration, and Katie will touch on that as well. Next slide. So one of the highlights of our work in the low-value care area is a really interesting multi-stake project that we did with our colleagues from Milliman regarding the measurement of low-value care utilization spending in 4 states. You see here, these are colleagues from Maine, Virginia, Colorado, and Washington. I'm just going to summarize our findings here just to say when people say it's not worth it to try to think about saving low-value care, you'll see that while we tried, next slide, to do an apples-to-apples comparison, even though all payer claims databases, or APCD, I thought mistakenly were somewhat homogeneous, even though these states had all payer claims databases, you could see that it's not truly maybe a Honeycrisp to Honeycrisp comparison, but I think it's apples to apples enough that we could say it's Gala to Macintosh to Honeycrisp, that we're able to get a real feel out of what's happening in these states, even though not all states had the same data elements. But fortunately, 4 states had both commercial and Medicaid, which is what we use to report in the next slide, to just get a rough feel of 47 measures in commercial and Medicare, approximating $1 billion. And these are 47 measures, in my opinion, that are not the most costly, but I think for our colleagues from Milliman Med Insight would agree, the ones we're most confident that we call them low value, they are really low value. So this is the spending of the 4 states on the 47 measures over time. You could see that in spite of implementations of things like the Choosing Wisely initiative and other programs attacking many of these, if not all of these 47 measures, there was a marginal decrease in spending on these, suggesting that we need to go further in addition to education and other types of interventions to think about payment reform and benefit design to reduce the use of these services. And you could find the list of these 47 services in the paper, which is easily found on our materials. Next slide. So one of the things that you know is very important to me personally is not just aggregate healthcare spending, what patients pay out of pocket. That has always been a high level focus of mine, in the fact that it bothers me enough that people have to pay high amounts of out of pocket for care they need. But this graphic shows you that in Maine, Colorado, and Virginia, the states that provided us information on out of pocket spending, that over 10% of dollars that went to these low value services in these 3 states were paid out of pocket. And while patients are struggling to pay their physician visit co-payments, to pay their life-saving drugs, and to get their DME, it's somewhat aggravating to me personally to see tens of millions of dollars in these states every year being paid out of pocket on wasteful care. Next slide, please. And if that's some of the negativity around low value care, I think as we turn to the optimism about potentially identifying and ridding the use of these services, what we found somewhat positively in all 4 states, that if you looked at the 10 most commonly used or misused services out of those 47, the total spending in commercial and Medicaid in those states all exceeded 2/3. And in the case of Colorado, Maine, and Washington, approached or succeeded 75% of spend, suggesting that these strapped states might be able to focus on a small number of low value services and to be able to pay off, as you see, in hundreds of millions of dollars a year, or approximating $6 per member per month in potential savings, for which most of you know we could buy a lot of high value services, including most of the services that are recommended by the VBID Center. Next slide. And just so when you add Medicare to this, the percentage of spending roughly stays the same, but the dollars almost double. So, and if we were able to get all of the Medicare data, it would even be worse. Next slide. So the good news is, I just want to show this paper by John Gruber at MIT, Kevin Volpe and others at Penn. A first study actually showing the impact of value-based insurance design, raising cost sharing on low value services, that was implemented by a large public employer in Oregon. And it should come as no surprise that, as my mother would tell you, that if you make people pay more for something, they'll buy less of it. This paper in Health Economics published this month does show that this VBID program that raised cost sharing on things like unnecessary diagnostic imaging or certain types of surgeries can actually lead to decreased utilization of those. No surprise. Next slide. So how do we put it all together? And I'll start wrapping up things here. Is Mike, for a very, very long time, had suggested that we build a specific benefit design around the VBID concept in a way that we could pay dollar for dollar all the increases in utilization and lower cost sharing high value services, and pay for that with bringing attention to low value care. Because the Trump administration and other payers turned to us to think about the use of this type of program in the exchanges, Mike cleverly called this VBID-X. Next slide. So VBID-X is fairly straightforward in the fact that you rob Peter to pay Paul. You take money from low value care and you use it to increase generosity on high value care services. And you invite these brilliant actuaries in the room to tell you that you don't have to raise premiums or deductibles. Next slide. And this idea came to fruition when Mike brought together 25 people from across the payer community, and we hashed and hawed and got the actuaries involved, and we came up with a list of high value services that we said these are so valuable they should be covered with no cost sharing, realizing that increasing all these things is going to spend money. Next slide shows another set of services that we did not bring cost sharing to zero, but because branded drugs tend to get a bad rap across the board, these drugs, without generic alternatives, were also deemed to be high value enough that they were put in a specialty drug tier that, because there were no lower cost alternatives, that patients should be able to get enhanced access to them. That cost us even more. So then came the tougher part of the VBID exercise, next slide, which is to identify services that we were no longer going to pay for. And you could see these are very much aligned with what John Gruber and others published and were used in the Oregon public employer space. And there are large private and public payers around the country now that have decided to no longer cover things like vitamin D screening for general populations, which many of you know has been my flagship low value service. And the next slide shows another set of services that we were not going to cover, but we were going to cover less generously. So lo and behold, to our great astonishment, we published this VBID-X report about a year ago. And then in late 2019, we noticed that the work that we had done was included in the proposed payment rule for 2021 and left open for comment. And we're even more astonished that in the final payment rule for 2021 was a section endorsing value-based insurance design and specifically the VBID-X programs. And you could go on our website and see that this list of services that was put together by Mike's VBID-X project is now permanently published in the Federal Register, making strong recommendations for the first time that many services should have their cost sharing reduced and be provided on a pre-deductible basis and paid for by reducing low value care. Next slide. So the takeaways, of course, is it can be done, and we'd love to work with any of and all of you out there who are thinking about just raising deductibles or increasing cost sharing in tough financial times because of COVID. There are infinite numbers of combinations of cost sharing and services and other types of things that it can help you meet your 2021 goals before you raise deductibles on my sick patients and make it even harder for them to fill their prescriptions or see me in the office or have to give up trade-offs of, as Mike said, food, rent, or transportation. Next slide. So I just want to bring attention to the fact that we're not just measuring, we're not just reporting, but there are ongoing efforts across the country to actually reduce low-value care. Our colleagues at the Washington Health Alliance and in Maine and Colorado and elsewhere, but the project that I'm most thrilled and horrified about, as my friends at the Virginia Center for Health Innovation know, is Smarter Care Virginia. And this is a multi-stakeholder effort involving not only the typical payer side, but many major health systems in the Commonwealth of Virginia working together to find processes to eliminate low-value care in phase one, to hopefully provide savings to allow more generous coverage of high-value services in phase two. Mike knows that's the holy grail for me, but we are very excited to be working with Beth Bortz and her team to see this come to reality. Next slide. So this is my close. I'm looking at the questions come in. I think I will digest them while Catherine gives her remarks, but I want to leave you with our view about where we think should go in the post-COVID era. First is, while deductibles will persist and will likely go up and enrollment in high deductible health plans is on the rise, consider pre-deductible coverage on the services you know are consistent with the mission or the culture of your organization. Implement plan designs like VBID-X. Talk to your EMR vendors, talk to your disease management vendors, talk to your employee benefit consultants to think about further nuance in your design to allow increased access to high value care and deter low value care. And in the meantime, since all of us, as Mike said, are really going to be trying to do more with less, we are here to help in the identification, measurement, and hope and potential reduction of low value care to allow you to preserve, if not provide more generous coverage as suggested in the Federal Register with benefit designs moving forward. So please, next slide, I think. Please, while Catherine is presenting, go ahead and enter your questions on the questions tab. But as I start looking through the questions that are coming in now, if we had more time, I'd have Mike introduce Katie, but Mike and I are both thrilled to have our very close colleague, Katie Spangler, give us an update on what's going on in DC and elsewhere in policy circles around value-based insurance design. And with that, Catherine, I'll turn it over to you.
Great. Thank you so much, Mark, and thank you, Michael, as well. It is my very great honor to be speaking after this esteemed panel, or at the end of this esteemed panel, with my two favorite academics, and I'm delighted to be here today. So with that on the screen here, you see some of the priorities of the Smarter Healthcare Coalition, which is a group of very diverse stakeholders based in Washington, D.C. that has been focused on implementing policies to pursue value-based insurance design and ultimately smarter healthcare in D.C. for the last few years now. So this is a listing of the things that have been our priorities. Not everything is on this list. For example, we recently published a white paper looking at social determinants of health and how you could alter the benefit design to help lessen some of the social determinants of health. So we can, I will cover now each of these in a little bit more detail so we can move to the next slide. Great. So this issue of allowing pre-deductible coverage of chronic disease prevention within high deductible health plans that are coupled with health savings accounts. This has been around for a long time. High deductible health plans coupled with health savings accounts were created in 2003 as part of the Medicare Modernization Act. There was a preventive care safe harbor, which basically said that you can have a high deductible health plan. You can still make a contribution to a health savings account, even if you're providing preventive care before the deductible. When Treasury published those rules in 2003, 2004, they were very limited in how they defined prevention. And so a lot of chronic disease prevention, or all chronic disease prevention, was actually precluded from being offered pre-deductible. Unfortunately, this was creating barriers to care for Americans with chronic conditions, especially as the deductibles, the number of people enrolled in high deductible plans increased pretty exponentially. So this is something, and Mark Fendrick has been working on this for at least a decade. We were delighted that last summer Treasury did publish this guidance document 2019-45. The document basically outlines 3 different bullet points that Treasury used to determine a very specific, and if you go to the next slide, you can see the specific list of conditions, or the list of services and drugs that could be offered for a very specific list of conditions. I will say, I don't know that any of us necessarily anticipated that Treasury would publish a specific exhaustive list. You know, we had hoped for more of an illustrative list, and I think it's easy to go from grateful to greedy. I know a lot of us are hoping that IRS and Treasury will expand this list, but in the meantime, we are absolutely grateful that we have this list that you have on the screen. And, you know, just taking insulin as one example of what's on this list, the idea that before, you know, it was questionable as to whether a plan could offer insulin for a patient that had diabetes. It is unequivocally clear now, and I know a lot of plans that this has been adopted by several plans, in the marketplace. So we're thrilled that this work is advancing. The guidance document does specify that IRS and Treasury will be revisiting this list and reconsidering this list. They estimate every 5 to 10 years in the guidance. But again, we can all be a little greedy and hope that maybe they would revisit it even more frequently than that. So we can move on to the next slide. In addition to continuing to work with the administration on various HSA policies, we're also working with Congress and Capitol Hill. We were delighted that Senators Thune and Carper, who have been very bipartisan champions of VBID for several years, and both members of the Senate Finance Committee, where all of the tax legislation is worked on in the Senate. We are thrilled that they updated the Chronic Disease Management Act to reflect this guidance document that Treasury published last year. And so this version of the Chronic Disease Management Act actually does allude to or mention those 3 bullet points that Treasury had used to determine that exhaustive list. And so we do think that this version of the legislation could allow additional flexibility beyond what Treasury and IRS have already said. And we think that that flexibility could be granted in a way so as to minimize any type of a federal score on this legislation and thus increase the likelihood that we could get this over the finish line. I will say, and I'm going to talk more specifically about the pandemic in the later slides, but I will just say quickly on this slide, this is something that the Smarter Healthcare Coalition is pushing very hard to get in the next COVID package. We think that just given the emphasis on folks with chronic conditions are experiencing COVID symptoms more severely, we think it's more important than ever that they have the tools that they need to manage those conditions effectively. So we can go to the next slide. Looking at VBID and Medicare, and again, this is something that the coalition has been working on for several years. I know Mike and Mark have also been working on this tirelessly. The gist here and the reason why the Medicare Advantage demonstration program is so exciting is that there has traditionally been a uniformity rule that has been applicable to the Medicare program. The gist there is that you can't treat one Medicare beneficiary better or worse than another one until this VBID Medicare Advantage demonstration program, which essentially said if you're an MA plan and you have an enrollee with diabetes and you maybe want to cover an eye exam for that patient, you could eliminate the cost sharing for that eye exam only for those patients with diabetes. And so this VBID MA program has been in effect for several years now. The statistics are on the slide about the number of plans participating and the number of beneficiaries that are benefiting from this program. This has also been, and this is a constantly evolving program, which has been really interesting to watch as it has evolved. And most recently, the biggest change I think that was announced was in January of 2019, just adding that for the VBID MA demo, you could include hospice benefits, which is very different than kind of the CMS, what CMS had said previously and the positions that they had taken previously. So we're excited to see that. There was a little bit of question mark as to whether that would be delayed because of the pandemic, but my expectation is that that does continue for calendar year 2021. One other thing that's not on here is just this notion, in addition to all the work through the demonstration program, there's also been successful work done on allowing more flexibility within Medicare Advantage plans, even outside of the demo program. And so I am delighted to say that CMS has allowed MA plans to vary benefits, vary Part A benefits and Part B benefits under the Medicare program. Unfortunately, that flexibility, that uniformity rule flexibility did not extend to Medicare Part D, but that is something that the Smarter Healthcare Coalition is working on. I am excited to say that that's something that both Senators Thune and Carper are also very engaged on, and they offered an amendment when the prescription drug bill was reported out of the Senate Finance Committee last year. It was reported with a successful amendment that they had offered to extend that uniformity rule flexibility to Part D, as it was already extended to A and B. So that's another thing that we continue to work on to allow Medicare beneficiaries to experience some of these great advantages of value-based insurance design that the commercial sector has employed for years. I will also say another win in the coalition's eyes is the Part D senior savings model, which caps out-of-pocket insulin costs for certain Medicare beneficiaries at $35 a month. The three main insulin manufacturers in the United States are all participating in that program, and my understanding is that they have also CMS has also gotten interest from many plans that are interested in participating as well. So with that, we can go to the next slide. Great. Okay, so decreasing low-value care, kind of the main emphasis of Mark's presentation, and have appreciated working with him on this topic also for a number of years. So last year, the Smarter Healthcare Coalition sent a pretty meaty letter to Secretary Azar asking that he utilize the authority vested in his office by the Affordable Care Act. So would just note that that was passed during the Obama administration, but that he utilized that authority to essentially say or allow Medicare to no longer pay, or to pay at perhaps a lesser level for any D-rated service as defined by the U.S. Preventive Services Task Force. So the letter, which is available on our website and a thrilling read if anyone is looking for additional reading material, basically it outlines the process that the U.S. Preventive Services Task Force uses. It lists at the time of writing of last August, the 21 D-rated services according to the U.S. Preventive Services Task Force, and it urges the Secretary to utilize that existing authority granted under the Affordable Care Act to help the Medicare program and the healthcare system as a whole transition to one that covers smarter care. To many of Mark's points earlier, just this notion that it's hard to find the resources sometimes needed to lower cost sharing and remove barriers to high value care, but we think this way of maybe making it a little bit harder to get low value care and investing those savings in higher value care is a way to achieve smarter care. And so we outlined all of that for the Secretary. I will say we've had some productive conversations with his team, and it does seem like something that they are taking seriously. With that, we did an op-ed recently, just kind of pushing the low value care, especially in light of COVID-19. And speaking of COVID-19, there has been a lot that has happened in the VBID space with regard to COVID-19. I guess it takes a global pandemic to realize that you do want people getting the care that they need when they need it. And it's been really fascinating to see how quickly policymakers have worked to lower obstacles to high value care during the pandemic. So first up was the March 11th IRS Notice 2020-15, which is published, which is effective, which essentially said that medical services and items purchased related to the testing for and treatment of COVID-19 may be offered pre-deductible in a HSA eligible high deductible health plan. So while many of us thought that testing and vaccinations would be fine, we were all, I think, thrilled to see that treatment was also included in this flexibility. Additionally, it does confirm that vaccinations continue to be considered preventive care. I will note that this guidance is caveated slightly with kind of the terminology of until further guidance is issued, this guidance is effective. So would flag that, I don't anticipate them changing this anytime soon. It was very broadly applauded, I think, by all stakeholders, that this flexibility was granted. So I don't anticipate that changing soon, but I did want to flag that. Next up, and again, I've never seen the administration and Congress move this quickly. If we could go back one slide, that would be great. But on March 18th, when Congress enacted the Families First Coronavirus Response Act, that did require, and I use the word require, I chose a lot of these verbs pretty carefully, but requires health plans to cover COVID-19 testing without cost sharing. I think folks are probably pretty familiar with that requirement. I'll add a caveat to that in a minute. But it did also say that any in-person telehealth provider visit, any in-person or telehealth provider visit that results in a COVID-19 test is also to be covered without cost sharing. I don't know if folks have seen some of the articles, but it is important to actually have that COVID-19 test accompany that visit, and to then follow the rabbit hole to make sure that that does show up on the bill if you did indeed receive that, because it does impact the cost sharing. So just a little hat tip for folks that unfortunately might be experiencing some of this in person. So if we can go to the next slide, you can see then on March 27th, the CARES Act was enacted. This kind of built on some of those provisions from the prior bill, and essentially says that one piece here was that HSAs that are coupled, HSA eligible high deductible health plans are allowed to cover all telehealth pre-deductible lasting through plan years beginning before 2021. Kind of a mouthful, but the gist is that, as we saw from Mike's slides, telehealth utilization did increase. In general, I think policymakers wanted to encourage and remove barriers to telehealth to limit exposure and to allow people to stay home. And so this was a really helpful policy to be included in the CARES Act. Again, it's not permanent, so it does sunset after 2021. Moving quickly, this also required all health plans to cover coronavirus vaccine without cost sharing within 15 days of a recommendation from the CDC. That's a pretty important one, especially that 15-day turnaround time. With other provisions within 2713 of the Affordable Care Act, which is the preventive services section that has a similar requirement, you have until the plan year beginning after the current, like the next plan year beginning after the recommendation is made. So you have a lot longer runway, but just given the importance of removing barriers to the vaccine, Congress felt like this was pretty important. Also just talks a little bit about that testing mandate from the previous bill and how that would need to be reimbursed by health plans. We can move to the next slide. The HEROES Act passed the House on May 15th. It did include a prohibition on cost sharing for COVID treatment. I just would asterisk that has not been enacted. I am somewhat skeptical, and this is my opinion, I am somewhat skeptical that would get across the finish line, because it gets a lot harder, very quickly, as opposed to just the testing and or the vaccination. A lot can go into treatment, and then we've already seen a lot of asterisks around just the testing, which leads me exactly to this June 23rd point, that there was guidance issued by the tri-agencies of Treasury, Labor, and Health and Human Services pertaining to that testing mandate that basically said that if it's not clinically indicated, and if it's testing to really facilitate return to work or facilitate public health infrastructure, or someone wants to travel to New England and they need to get a test, that's not necessarily covered under this testing mandate, and they're pretty clear in saying that that's outside the scope. So quickly, in the 1 minute we have left, we'll pass to the next slide. One back. So VBID continues to be very, very purple. It has been a really excellent issue to work on. Just the example of the VBID Medicare Advantage demo really began during the Obama administration. It was expanded during the Trump administration. I don't know how many healthcare policies have the privilege of saying that, but VBID absolutely does. And then also, just the VBID mentioned in a couple different places in the Biden-Sanders Unity Task Force recommendations. So I think, obviously none of us know what's going to happen in November, but I think, it feels like VBID, all bases are covered with VBID, given the extreme enthusiasm from the Trump administration and also the inclusion in the Biden-Sanders Unity Task Force. So with that, I will turn it back over to Mark.
Catherine, thank you very much. You've filled our entire allotted time. I want to thank you very much and Mike, and I want to let the folks who've submitted questions via the web tool, will be answering many of those. Katie, I think we could basically say that through the VBID Center newsletters and the information put out by the Smarter Healthcare Coalition, we can make sure that the attendees get kept up to date on our activities on low value care, as well as policy movements in Washington. As I look through the questions as I get ready to sign off, I know there'll be no football at Michigan this fall. That probably gives Susan Lynn a little more time to think about our next VBID summit in person, which probably will not be until the 2022 calendar year. But I do want to thank all of you on the line, particularly those who supported the VBID Center and the Smarter Healthcare Coalition as we've taken on this slow and steady movement to spend our healthcare dollars better. And you see here on this final slide how to reach us at the VBID Center. As we said, there is a landing page for the website webinar. All of the slides are there, as well as many of the resources that Mike, Katie, and I spoke about. And it's our hope to stay in touch with each of you. Please reach out to us if there's something specific that you'd like us to address. Again, thanks to Susan Lynn Osterly and her team for putting this webinar together. And I wish all of you a great rest of the afternoon, and please stay safe until we get back to normal. Thanks very much. This will conclude the webinar.